environment. So our next speaker, we're very pleased to have Dr. Laura Tang, who's going to do classification, the new classification that I'm sure all of you are familiar with, of NETs. And I think is she about? Oh, here, okay, sorry. Thank you very much. Just come forward. Thank you.
Thank you for being here, and it is so exciting to see so many patients here. The reason for that is I do not normally see patients. I am a pathologist from Memorial Sloan Kettering Cancer Center, and I'm sorry I didn't have the opportunity to ask the questions you have before my presentation. But I'm going to try my best to address some of the important issues in diagnosis of this particular tumor. So when you were told that you might have this disease, instantly you reach out for different things, such as tests for like imaging or blood or urine test, or even some more fancy molecular tests. And you may be also seeing a nuclear medicine people, and to have octreotide scan or gallium scan done. And you may be suggested for PRRT treatment. And also you may be seeing an intervention radiologist to either have a biopsy, or if you have a liver tumor, they may ablate that tumor. And you are shopping now for the best surgeons or more experienced oncologists for this disease to treat your disease. So where is pathology in this picture? You don't see it anywhere here. Although many of these tests are very, very important as a component of your disease management. However, pathology is still the gold standard for the diagnosis of this disease. Without pathology diagnosis, most physicians will not treat your disease. And also, if you have a wrong diagnosis, you're going to have a wrong kind of treatment. You may be harmed for such a treatment. And also, even within so-called neuroendocrine tumor, you may have different subtypes of tumor which is going to be treated differently. So it is very critical to have diagnosis, tissue diagnosis, even if you have to wait for a few days extra, but it is very crucial. So what do we do in pathology here? I just want to explain to you. I'm sorry if I'm saying things you already know, but I want to make sure that everybody gets some information out of my talk. So you first of all, you may have your tumor removed in the case of before diagnosis, in case of emergency situation, such as a bowel obstruction or bleeding. Or you have a tumor, the physician needs to know the diagnosis, biopsy of a small incision is performed, or sometimes we use a needle to aspirate a few tumor cells, which may be adequate for the diagnosis. Sometimes the tumor is cystic, or you have a fluid collection in the abdominal cavity or chest, so we may aspirate that fluid for the pathology diagnosis. When a tissue comes to us, we examine the tissue, we describe it, the size, the tumor, the shape, the color, and consistency. All of these are components of pathology diagnosis. And then the tissue goes to the pathology lab. We first fix that in formalin, and then embed it in paraffin block. Here you have a piece of tissue, tumor tissue, and then the paraffin block. And then a very thin section, about 4 micron, is processed like this, and then put on a glass slide and stain for hematoxylin and eosin, which is so-called H&E stains. And then now the tissue is ready for examination by a pathologist. So we use a microscope as an initial diagnosis. So with experience that we can make the correct diagnosis most of the time. However, in other situations, we may need additional studies. We may have to use one of these so-called unstained material to do some immunohistochemistry, either to confirm the diagnosis or in the situations when the tumor comes to us as unknown primary. So we have to solve the mystery where the tumor is coming from. And also we can assess some prognostic factors such as Ki-67, which was mentioned in the last talk. And now we even have some additional molecular studies. We can examine your DNA and RNA to see if there are some important targets we can use for treatment or prognosis. So you probably have experienced this before when you go to see a different doctor. Oftentimes they ask you to have the tissue block from the original hospital. So here's the tissue block, or unstained slides, which are these thin slides put on the glass slide without any stains, so we can perform these additional studies. So in pathology, I think our role is complex, and we're in the process of pathology evaluation. We need to classify the tumor by tumor grade and tumor stage. Tumor grade tells you how fast the tumor is growing, and stage tells you how far the tumor has gone from the primary site. And within this process, we can evaluate some therapeutic markers as well as prognostic markers. And in this process, we facilitate and help the treating physicians with the correct treatment and can predict your prognosis. So my outline is going to be focused on pathology, overview of neuroendocrine tumor in pathology, and some specific issues of neuroendocrine tumor with the pathology diagnostic dilemma. So the difference between a neuroendocrine and endocrine is that you have there two classes of categories. One is endocrine. Usually there is an organ that you can see or you can image on a CT scan or X-ray. So these are thyroid and parathyroid in your neck, adrenal gland on top of your kidneys, and pituitary gland in the brain. However, the tumor we're dealing with are derived from the so-called neuroendocrine cell system. They do not have a grossly identifiable organ. You can only see these precursor or the normal cells under the microscope. They include pancreas, lung, gastrointestinal tract, as well as paraganglia, which is more of a neuro than endocrine. So this is so-called a diffuse neuroendocrine cell system. So this is an example of a gland from a gastrointestinal type mucosa lining. And these are the normal epithelial cells responsible for nutrition absorption. And you have these additional cells scattered throughout the glandular system, and they have a very long dendritic processes reaching out to the adjacent cells. So these are so-called diffuse neuroendocrine cells. Normally, they perform their physiological function via many different mechanisms. One of them is to release peptide hormones or neurotransmitters directly attached to the adjacent cells. There are receptors for these peptides, or they can be released to the bloodstream, which is working throughout the entire body. So in the pancreas, we think at least a subset of tumors, such as functional tumors, insulinoma or glucagonoma, are derived from these so-called cells of Alice. So under the microscope, you can appreciate this small structure, which is a group of endocrine cells, and beta cell responsible for insulin secretion, and when you have insulinoma, which is abnormal insulin cell proliferation, or glucagon cells, called alpha cells. So we know some of the tumors are derived from this normal structure. However, there's a large population of non-functional tumor. We don't know exactly what's the cell lineage. So this is already mentioned earlier. The most common type of neuroendocrine tumor in the gut is a small bowel. And I have this second picture showing that the prevalence and the prognosis of gut neuroendocrine tumors. And as you can see, it seems like the tumors at both ends, they have a better prognosis. This is a combination of the intrinsic biology of the tumor as well as the location of the tumor, because in these two ends, it's very easy to be approached by endoscopy, so oftentimes they're detected earlier. For example, rectal neuroendocrine tumor is not completely benign. However, they are identified earlier, so they presented with an earlier stage, so they're treated earlier. Stomach neuroendocrine tumor, there are two different types, and type 1 is biologically relatively benign, so they do better. However, it's very important for us pathologists to recognize there's a type 3, which is not such a benign tumor. And for the small bowel, as mentioned in the last talk, the issue is the early diagnosis is difficult because they cannot be reached by routine endoscopy, upper or lower endoscopy. So oftentimes they are discovered much later. So the prognosis is worse correspondingly. So just in summarize the pathology of GI and the pancreatic tumor, it is a heterogeneous group of tumor, and they all express neuroendocrine markers, but it doesn't mean they are the same tumors. So it's very important to recognize it's under the big umbrella, but with many different subtypes. And histogenically, unlike a carcinoma of colon cancer, breast cancer, usually they are derived from the epithelial cells, and these tumors are derived so-called diffuse neuroendocrine cell system. The nomenclature is incredibly important because there has been many confusion how to call this tumor, and I'll show you another slide later. But at the moment, I think it is incredibly important to recognize the well-differentiated and the poorly differentiated. It's not only about the degree of a differentiation. They are completely different tumors, and they started from different lineage, and they have completely different behavior, and most importantly, very different treatment. So the well-differentiated ones are classically described as a carcinoid at some size, or now I prefer to use a NET. And the poorly differentiated, these are carcinomas. So there's no other explanation by this. So as a pathologist, as I said earlier, we review these H&E stain slides under the microscope, and we can have a pretty good sense what type of tumor these are. For example, these are neuroendocrine tumors from different anatomic sites. It is very obviously, you would say that when you have a small bowel biopsy, you have a small bowel tumor. It's very easy to recognize is the primary site. However, oftentimes we get a biopsy is from liver metastasis, and it comes with a history of unknown primaries. So we are in the mission to identify where the primary site would be. So with some experience, we can have a pretty good sense. For example, the duodenal tumor has a specific morphology, pancreatic, rectum, and small bowel. So it is very important to seek experienced pathologists to have this assessment initially. So now I'm going to address some critical issues in pathology, and there has been some confusion, carcinoid versus carcinoma. Again, I want to emphasize these are completely two different diseases. And differentiation is not just the degree of differentiation. Again, these are two different tumors. I'll address that in more details later. And the grade is quite complex. We'll address that as well. So when you look at the old classification system, it's very confusing because lung has its own classification, and then the European Neuroendocrine System Society has a different way to do this, and WHO has a different system, and here is AJCC and other systems. So basically, they all try to assess the grade of the tumor and then the stage of the tumor and combine them in some way, which is very confusing. So perhaps it is complex because we really don't understand the system very well. So how can we simplify such a complex system? So at the moment, I think most importantly, we need to use a terminology which is clinically relevant because there are many other systems, maybe an academic exercise at the moment. So again, I want to reiterate the importance of these two categories, well-differentiated and poorly differentiated. One is NET and one is NEC. So WHO use proliferation as a classification for a tumor grade. It is important to realize that well-differentiated NET has different grades, and they can be assessed by mitosis. I'll show you how to do it, and Ki-67. So when we examine a slide under the microscope and we look for mitotic figures, and the so-called high power field, that's a 2 millimeter square field under the microscope, and we have to count at least 10, and then the number of mitoses within this 10, so it's expressed as number of mitoses per 10 high power fields. However, this tumor, as you know, is relatively indolent, so oftentimes there are 0 if you only count 10. So we tend to count more. We count 50 fields. So we average that and express as 10. As you see, when you count 50, it has a better prognostic value in this. And also the tumor oftentimes is heterogeneous. So when you have a tumor resected and then it's put in many different blocks, and we have many different slides to review, so we like to assess all of them to identify the mitotic activity accurately. So here's another way to assess the proliferation, which is a Ki-67. It is marker to detect a tumor in proliferative status. So you may have a very low one, intermediate, and a little bit higher. Again, this is happening within the same tumor, so we really have to examine the tissue very carefully. So again, regarding heterogeneity in grade, and there are some subtle changes. Again, this is within the same tumor. You can see they're very similar, but with the subtle changes. The nuclei are slightly bigger, and then again, you're seeing all of a sudden too many mitoses. So this is a higher grade component within the same tumor. Another sign of a higher grade is presence of these very small pockets of necrosis, because the tumor cells are dying because they are growing fast without vascular supply, without nutrients. So what's the relevance of a tumor grade in a well-differentiated tumor, particularly between G1 and G2? Obviously, we can predict prognosis. However, it is really not that significant in terms of treatment at this point, unless you have an obvious clinical progression. You have more symptoms, and the tumor is enlarging on the CT scans. So I think it is not too it's kind of crazy that when you argue you have a tumor which is 2% Ki versus 3% Ki, is not a huge difference. Clinical factors are more important in this setting when you are dealing with a well-differentiated lower grade tumor, G1 and G2. And G3 is a different story. We'll talk about that later. So we talk about the well-differentiated NET, which is its own class. It have a different grades. In the poorly differentiated NEC, it is almost always high grade, although there are some numbers here, but this is not the only criteria to diagnose a poorly differentiated neuroendocrine carcinoma. As I mentioned many times earlier, this is a completely different disease. And clinically, the progression is very fast. Usually it's positive for PET scan and oftentimes negative for somatostatin receptor analog scans. And serum markers such as carcinoma markers are usually elevated, which is usually not present in NET. And morphologically, we can recognize the difference between NET and NEC most of the time. And another interesting thing is commonly seen in association with another type of cancer. For example, you may have a colon cancer as a component of a high-grade NEC, or esophageal cancer or gastric cancer. So it's a true carcinoma. That's why it's very misleading to put this tumor into the neuroendocrine category, because it's a different disease. And although they express neuroendocrine markers, but doesn't mean it is related to a NET. And they are responsive to chemotherapy, but oftentimes refractory, and the prognosis is not too good. And most importantly, they are treated completely different from NET. So here are some examples of poorly differentiated NEC. We think they started off as a conventional carcinoma, and they may have these transformation. You may probably have heard large cell and small cell type. So we really think it's just a variant of conventional carcinoma. So morphologically, as I mentioned, they have some distinct features, such as instead of a small pockets of necrosis, these are huge areas. We call it geographic pattern of necrosis, and they may have a combined component of conventional carcinoma versus NEC. And this is an example of a small cell, and this is an example of large cell neuroendocrine carcinoma. And again, just to summarize the difference between this tumor and the NET is that histogenesis-wise, they're not derived from a diffuse neuroendocrine cell system, and they only have high grade. They don't have a spectrum of grades, and they may have a coexisting carcinoma. And the molecular genetic study has demonstrated they are very closely related to adenocarcinoma. Or squamous cell carcinoma. And these features I mentioned, PET scan is positive, and carcinoma markers such as CA 19.9, these are oftentimes elevated, and they respond to platinum-based therapy. So just to put them side by side, to emphasize the difference between NET and NEC. So NET, again, is from diffuse neuroendocrine cell system, or cells from the pancreatic islets. And they are a unique group of tumors, and oftentimes low grade. At this stage, you have stable disease. And when it goes to a higher grade, you may have disease progression. In contrast, the poorly differentiated NEC is carcinoma to start with, and then they undergo some genetic transformation, becomes a high-grade neuroendocrine carcinoma, and then the prognosis is poor. So this may not be the perfect analogy, but I will do anything for you to register the importance. So as you know, married people usually share the same last name. In this case, it's Mr. and Mrs. Neuroendocrine. But usually, biologically and genetically, you are completely unrelated. So these are no offense to the gentleman here, but just to emphasize the importance of the difference between the two tumors. They are both labeled as endocrine, but they are completely different diseases. So staging was mentioned earlier. Early on, most of us use a European system because it was established earlier. Now we have the AJCC of our own system. Currently, we use the 2009 version, but as mentioned earlier, the 2016 version is going to come in 10 days. And whatever we use, we have to specify because there are some differences between these different staging systems. So I want to use a few examples just to emphasize the importance in pathology diagnosis of neuroendocrine tumors. When you have a small tumor which is collected from a needle, we call a fine needle aspiration, or fluid, or even just a small biopsy. And the diagnosis can be challenging, although one can read books, and these are the descriptions, but when you're dealing with a reality, it's not such a straightforward situation. For example, there are few cells we collected from fine needle aspiration, and it goes along with the description by the book. Smaller cells and hanging on a very thin vascular core, loosely cohesive, and they have abundant cytoplasm and stands for neuroendocrine marker chromogranin. Here's another tumor which the cells are a little bit bigger. Again, it stands for neuroendocrine marker chromogranin, and we render a diagnosis of neuroendocrine tumor, which is not wrong. However, the difference is this is not a true conventional neuroendocrine tumor. It's actually a pheochromocytoma, and it is very important to make this diagnosis before surgery because these tumors produce epinephrine, and then you may get into a hypertensive crisis. So the patient needs to be prepared and protected before going to surgery. And so in my view, a diagnosis of neuroendocrine tumor is only halfway done. One really has to distinguish between these two categories, as well as a situation of a combined neuroendocrine tumor, and in the situation of a pheocytoma is very critical as well. So when dealing with a small biopsy, we should be able to distinguish between epithelial, which is usually a conventional NET, and non-epithelial, which is a paraganglioma. And we definitely should try to provide differentiation well to poor. And grading can be difficult because you have very few cells. You don't get 10 fields to count mitosis, but we should be able to provide whether this is a high grade or non-high grade, indicating whether it's a well-differentiated category or poorly differentiated category. Another interesting topic of mine is gastric neuroendocrine tumors. I want to give you an example. When you look at these two tumors under the microscope, they look very similar, even in my eye. So these are two different patients, patient A and B. Both were diagnosed with a neuroendocrine tumor. So both were followed by endoscopic surveillance. However, the difference is that one patient is still alive after 15 years, another one did not do too well. So what did we do wrong? I mean, these two tumors, they look very similar, and they are actually both a G1 grade. What we didn't do is we failed to subtype these two tumors. Type 1, as I mentioned earlier, is an indolent tumor, and type 3 is more malignant and should be managed as a routine carcinoma. So for us, with the combined pathological features as well as clinical information, we should be able to distinguish between the two subtypes. Type 1 is usually multiple and has a background of neuroendocrine hyperplasia, and the tumors are usually very small, and the stomach mucosa is abnormal. is atrophic, because this is an autoimmune condition. You're generating your antibody against your own acid-secreting parietal cells, so the stomach is atrophic without the acid-secreting component. And as I mentioned, the management is completely different. And another issue is in the liver biopsy. It is very challenging for us because oftentimes it comes with unknown primary or no specific clinical history, and the biopsy can be very small and suboptimal in preservation. So I want to give you an example just to, again, emphasize on the importance of a correct diagnosis and correct treatment. So this is a case of somewhat misleading and misunderstanding. And so this patient had a history of breast cancer, which is all the way back to 1994 and recurred in 2001. With metastasis to lymph nodes, and then later in 2009 presented with abdominal pain. As you can see with the history, it's very, very easy to go down to the wrong track, that this is probably a metastatic breast cancer. And the liver, a CT showed multiple tumors. And again, we get a very suboptimal, very difficult small fragments of tissue diagnosis is challenging. And this patient came from outside, and the diagnosis is metastatic breast carcinoma, which is definitely possible. Again, the patient is not doing too well. So the oncologists need a diagnosis instantly, and we need to treat patient, in the next few minutes. So the pressure is on us, and so however we have to be a little bit careful in this situation, and we didn't render a definitive diagnosis. Initially, we said could be a metastatic breast, but just by looking at a tumor, it could be something else, and we need to work it up. We need to compare this current tumor with her prior breast to see if they share any morphological similarity. So as you know, because we're talking about neuroendocrine tumor, this tumor has some features suggestive of a neuroendocrine tumor. So we obtained the unstained slide I mentioned earlier from a new cut from that block. And we did a neuroendocrine marker, which is indeed a neuroendocrine tumor. And estrogen receptor, progesterone receptors are negative, so it's probably unlikely to be a breast cancer. And here is the current tumor. And then here we asked the question, because based on the morphological features, I thought about the pancreatic primary. And then we got answer of no tumor in the pancreas. However, there's a mass in the spleen. So you can see tumors in the liver, and then here's the spleen, a tumor. But one has to realize what's between the liver and the spleen is pancreas, right? So when you look at different cuts, indeed here's pancreas, and you see a tumor here, and another tumor which goes into the spleen. So this is likely a pancreatic neuroendocrine tumor. And then we got additional information. The patient is having a watery diarrhea, and because of the severity of diarrhea, there's an electrolyte imbalance. And then this also triggered another thought, because in the pancreas neuroendocrine tumor, there's a particular subtype, which is vasoactive intestinal peptide producing tumor, VIP. We did an immunostain, indeed it is positive. So by then, now 2 or 3 days later, we eventually got her breast tissue to compare. They are similar, but they're different. So eventually we rendered a diagnosis of a well-differentiated neuroendocrine tumor. A specific subtype is lipoma. And finally, I just want to mention the challenge in pitfall in the diagnosis of neuroendocrine tumors. As I mentioned, sometimes we get a very small piece of tissue and they may be crushed and not better preserved. So this tumor definitely has a morphology of a high-grade small cell carcinoma. In this situation, the Ki-67 would be helpful. Again, this tumor is crushed, has a very poor preservation. However, when you do a Ki-67, this is actually a very low-grade tumor. So in terms of pathology diagnosis, a few years ago, we got together with a group of oncologists and pathologists, and we have decided to use at least a minimal data set to report this tumor. So we need to provide information for diagnostic classification. Again, well-differentiated is completely different from poorly differentiated tumor. And we need to provide information to grade the tumor, which is counting mitoses and do a Ki-67. And information for staging, which is the size of the tumor and how deep it has invaded into the, for example, small intestinal wall. And immunostaining is necessary to both to confirm the diagnosis, such as neuroendocrine markers. And again, for a surgical resection, we need to comment on the margins of resection. And finally, there are other prognostic factors should be reported in the pathology report as well, such as the presence of tumor necrosis, which is indication of a higher grade tumor, and also a lymphovascular invasion, which is also an adverse feature for metastasis. And third, there are evolving therapeutic markers coming along, so we'll have more information in the coming years. So the take-home message for this talk is that a pathology diagnosis without a classification of the tumor is not acceptable. We must start with the tumor differentiation and then grade the tumor. And pathology, although is the final word, is the gold standard, sometimes we need a clinical input, particularly when we're dealing with unknown primary. Some of the clinical features can be helpful to facilitate the diagnosis. And therapeutic decisions should be based on tumor biology. Again, these are completely two different tumors. That's the biology of the tumor, and the tumor grade and stage, and also evolving available biomarkers. So if you don't know about pathology, usually we're blamed for being too slow, and so this is probably a pathologist, and this is probably a surgeon or oncologist. However, if we are equipped with the important information, we can really go fast. Thank you very much for your attention.